Hi, I'm Dr. Robert Clark. I'm an associate clinical professor of ophthalmology at the Stein Eye Institute, UCLA, and physician owner of South Bay Family Eye in Long Beach, California. I presented the following talk as the Stickle Lectureship in Ophthalmology in May 2025 at Washington University, St. Louis, but I believe this information is too important to restrict behind an academic firewall, so I created this video with much of the same information. Despite growing recognition of myopia as a leading cause of untreatable impaired vision worldwide, myopia control in children is still not considered the standard of care. Significant doubts exist for many eye doctors. Primarily, does it really work? And is it really worth it? Do the outcomes justify the extra time and energy for a disease that we treat successfully for decades with glasses, contact lenses, and refractive surgery? I will address those questions today. These are my disclosures. The grant support is for unrelated topics. CooperVision, SigNexus, and Vialuma are involved in myopia control. My goals for this lecture are to give you an update on the current state-of-the-art in myopia control, to go beyond the published literature to share information that is not widely known. I will also try to answer the following questions. Does current evidence support efficacy? Does current evidence support safety? And finally, do we have enough data right now in 2025 to support myopia control in children as the standard of care? Before we jump into childhood myopia, I want to set the stage with an anecdote about my oldest daughter. My daughter had an underbite and crossbite and started treatment at age 8 with a palate expander. This medieval torture device uses a central screw mechanism to widen the metal brackets, one turn at a time, over several weeks until the palate separates to widen the bite. Then she had braces for about 8 months to limit the crossbite and straighten her teeth. Then she wore permanent and removable retainers for years into adulthood to maintain alignment. Then she decided at age 25 that a small space that had developed in the front was a problem, so she used Invisalign for 2 more years. Now, 20 years later, after more than $10,000 and countless visits to the orthodontist, she has straight teeth. All this time, energy, and money, not to maximize vision for a lifetime, but to straighten teeth. Her orthodontist did not spend any time at any visit justifying his treatment, explaining to us the importance of straight teeth and a proper bite. He did not need to. Every parent wants their child to have straight teeth, and getting braces is just another childhood rite of passage. He also did not waste time justifying the price for care, other than to provide us with a payment plan option. Instead, his interactions with us were always very short. This is the problem, this is my treatment plan, and this is the price. Let's get started. Time for our first fact or fiction. We should control myopia progression in children. I won't spend much time on this point because all the major eye organizations, including the American Academy of Ophthalmology, believe myopia control in children is a high priority. The benefit for reducing myopia progression is similar to the benefit for reducing blood pressure to prevent stroke and eye pressure to prevent glaucoma. Each diopter of myopia progression over 3 diopters, not the 5 or 6 diopters that define high myopia, increases the risk of serious eye disease by about 40%. And there is no effective adult treatment, no Ozempic or gastric bypass surgery, to shed the excess millimeters of eye growth. Myopia can only be controlled in childhood to reduce the risk of uncorrectable vision loss later in life. I want to emphasize that the risk of visual impairment from myopia start at a much lower level than high myopia. The risks for retinal detachment, glaucoma, cataract, and myopic degeneration start to exponentially increase at 3 diopters. We should not wait for progression or restrict treatment for children with lower myopia in an attempt to conserve our resources to prevent high myopia. There is a dangerous concept that many eye doctors believe in, that there is a normal range of myopia, a level of refractive error that is not a disease but rather an inconvenience, compared with a bad level of myopia that is high enough to be pathologic. In a 1988 study of almost 1,200 Japanese patients with non-traumatic retinal detachments, compared with about 12,000 control patients, the risk for low myopia, minus 0.75 to minus 2.99 diopters, was 3.1 times the risk of emmetropic patients. To place that level of increased risk into context, not treating high blood pressure increases the risk of stroke 3.5 times and heart attacks 2.4 times. Clearly, high myopia is much worse than low myopia. but any level of myopia increases the risk of uncorrectable vision loss. Our goal should be to reduce the final of myopia for every child, but definitely keep the final refractive error below 3 diopters, if at all possible. Time for our second fact or fiction. Myopia control in children is possible. The current treatment options fall into two broad categories. Pharmacological, primarily low-dose atropine eye drops of various concentrations, and optical, including rigid contact lenses and multifocal soft contact lenses and glasses. Atropine eye drops probably have the longest clinical usage to prevent myopia progression. There are published studies dating back to the 1970s documenting the efficacy of atropine 1% in slowing myopia progression, but the side effects of prolonged pupillary dilation and blurred near vision prevented widespread adoption until the 2012 ATOM-2 study demonstrated a much lower concentration, 0.01%, retained much of the efficacy of 1% without any known side effects. Low-dose atropine drops have been studied over a broad age range, 3 to 17 years, and there are now more than a decade worth of randomized controlled trials demonstrating benefit over placebo, except for the 2023 PEDIG study, which showed no benefit for US children. The following reanalysis of the PEDIG trial data was the basis for my 2025 APOS poster. The original study was a randomized clinical trial of nightly atropine 0.01% versus placebo for 24 months in a US population. The main outcome was the change in average cervical refractive error, SER, after 24 months of treatment, followed by 6 months of washout. The headline result was that no treatment benefit was observed for the atropine group, which actually had slightly more average SER progression at 0.94 diopters versus 0.88 diopters for placebo. A closer look at the published manuscript, however, reveals some anomalies in the results. Here is their figure 2a plotting change in SER over time. Orange represents atropine and blue placebo. Atropine slowed progression of myopia over placebo until 18 months, but the advantage disappeared by 30 months. Their interpretation was that atropine lost its treatment benefit over time. That is not what happened. A best fit line for the atropine subjects suggests a stable rate of progression for 30 months, no loss of effect. A best fit line for the placebo group does not work as well. There was a distinct break at 18 months. There was one rate of progression for the first 18 months, and a different, slower rate of progression between 18 months and 30 months that allowed the placebo group to catch up. What happened during that second year on placebo? I found an identical trend in another recent randomized controlled trial of atropine versus placebo in Western children, the 2022 Western Australia ATOM study. This graph is figure 1 from the manuscript. For both spherical refractive error and axial length, the atropine group has a statistically significant advantage over placebo until 18 months, when the rate of progression of the placebo group markedly slows down. Here, the authors have an explanation for why the placebo group's rate changed so dramatically. Significantly more placebo subjects dropped out of the study at 18 months, 25%, versus 10% of atropine subjects. And those that dropped out had progressed an average of more than 1 diopter, compared with those that stayed who progressed an average of 0.5 diopters. In other words, parents of placebo subjects with fast progression pulled their children from the study, since clearly the treatment was not working, leaving only slow placebo progressors for the final study visit at 24 months. Since the PEDIG study was funded by the National Eye Institute, their dataset is publicly available. We divide their subjects, both atropine and placebo, into slow progressors and fast progressors based on progression at 12 months. Slow progressors had minimal progression, less than or equal to 0.25 diopters, while fast progressors had more than 0.25 diopters progression. We then analyze the outcome of the fast progressors. Why fast progressors? Slow progressors have no reason to be concerned. The treatment seems to be working. Fast progressors, on the other hand, might be incentivized to drop out of study or use off-protocol treatment, since they are getting worse on treatment. From our analysis of fast progressors, the reason for the change in rate of progression for the placebo group in the second year of the study became clear. Non-physiologic hyperopic SER changes from 12 to 24 months. 18% of placebo eyes with fast myopia progression from baseline to 12 months had hyperopic SER changes from 12 to 24 months, compared with 4.1% of atropine eyes. Only one clinical factor was associated with this non-physiologic hyperopic change: Asian race. 3 of 5 aging placebo subjects ended 24 months on treatment with less myopia than at baseline. What caused this anomalous outcome? To figure that out, we need to adopt the mindset of an Asian parent enrolled in this study. Our child has been taking their eye drops regularly for a year, and their vision got worse. They are in the faster progressing group. Do we keep using the eye drops, which we believe are probably the placebo since they aren't working, or do we change therapy? And what is the go-to therapy for a lot of Asian children? Orthokeratology, which induces a hyperopic SCR change by flattening the central cornea. Removing all Asian subjects from both study groups markedly cleaned up the graph of SCR progression over time. The treatment benefit for atropine observed at 12 months was now maintained through 24 months. I believe that it is very likely that a significant percentage of fast-progressing placebo subjects used off-protocol treatment to slow their fast myopia progression, confounding the primary outcome and collapsing the difference between placebo and atropine. The PEDIG study and the WA Adams study uncovered a fundamental flaw in all recent myopia control treatment studies. Subjects can be masked to their treatment, but they can't be masked to their outcomes, and they'll be incentivized to go off protocol and drop out or use another myopia control treatment if they experience myopia progression. Does low-dose atropine work? Clearly yes, since even in the PEDIG study, only the placebo subjects had poor enough outcomes to go off protocol to confound the primary analysis. More than a decade of research and multiple randomized controlled trials support safety and efficacy. The last point, however, is the most important. Given the presence of known effective treatments to slow childhood myopia progression, it will not be possible to generate clean data from multi-year placebo-controlled trials. Apart from the ethical dilemma of withholding treatment from children with a relentless, irreversible progressive disease, patients and parents cannot be masked to their outcomes. They will know if the treatment is not working and either drop out or seek alternative therapy. In other words, right now, we have the best placebo-controlled data on slowing myopia progression in children that will ever be obtained. What about optical treatments to slow myopia progression? It has been known for many decades that visual feedback can regulate focus. More than simple deprivation causing axial elongation and myopia in chicks, plus and minus lenses can actually modulate eye shape to compensate for the induced image blur. This globe-sized modulation in response to visual feedback has been demonstrated in every species study: birds, fish, and mammals. The vision-dependent mechanism appears to be localized within the eye, since it occurs even if all nerve inputs and outflows are severed. It is also regionally selective. In other words, the change in eye shape can be induced along a single meridian instead of the entire eye if an asymmetric visual input is used, meaning that it is independent of accommodation in eye pressure. The key insight is that the peripheral retina, not the fovea, is the main driver for this behavior. That seems counterintuitive, since optics and accommodation are designed to create a clear, focused image on the fovea. But the compensatory change in eye size in response to abnormal visual stimuli has been observed in animals that lack foveal differentiation, and is preserved if the fovea is completely ablated in the species with a fovea. This image is the key one to remember when thinking about all the various types of peripheral defocus glasses and contact lenses that have been studied. In this experimental setup, the monkey is wearing opaque goggles with a clear central hole to permit normal central vision, but image blur for the peripheral retina. It is possible to recreate all of the induced focus and globe size changes that occurred with complete form deprivation by just blurring the peripheral retina. The peripheral retinal signal dominates the vision-dependent changes in eye shape. This series of figures depict emmetropic human eyes, but with very different shapes. A prolate eye is long and skinny, i.e. longer axial length, but shorter transverse diameter. A spherical eye has symmetrical axial length and transverse diameter, while an oblate eye has a shorter axial length compared to transverse diameter. Remember, each of these eyes is emmetropic, with a central image focus on the fovea, 20/20 vision without correction. But the key insight is that the prolate eye already has peripheral hyperopic defocus, which from animal experience should induce myopic progression. That is exactly what is observed. Children who are emmetropic, but with a prolate eye shape, become myopic at 2.5 times the rate of spherical or oblate eyes. What happens if the child does become myopic and receives single vision glasses or contact lenses? With correction, the central image plane is pushed back onto the fovea, restoring clear central vision. But the peripheral hyperopic image is pushed even further behind the peripheral retina, increasing the signal for more myopic progression. Single vision optics create a vicious cycle. The more myopic children become, the more they wear their glasses. The more they wear their glasses, the more myopic they become. The optimal correction is multifocal, with a central focusing element for clear foveal vision and peripheral hyperopic focusing elements to move the peripheral image plane anterior to the retina. This core principle underlies most current optical treatments to slow myopia progression. Does peripheral defocus actually work in clinical practice? Even before we understood the physiology, doctors have advocated for various strategies to reduce peripheral hyperopia. Simple undercorrection does not work, since even the undercorrected myopic eye typically retains some peripheral hyperopic defocus. Standard bifocals and progressive lenses work somewhat, since a portion of the superior retina has the proper defocus from the act. But executive bifocals that cover the entire superior retina with defocus works better. Finally, custom-designed defocus glasses and contact lenses work the best, since they treat all 360 degrees of the peripheral retina. This type of dose-response effect, with larger areas of the peripheral retina covered by the defocusing elements creating a stronger myopic control effect, is very reassuring that we are on the right track. What are the current treatment options for peripheral defocus contact lenses? Let's start with the only FDA-approved treatment for myopic control in children, the CooperVision MiSight soft contact lens. The labeling indication is for children ages 8 to 12 with minus 0.75 to minus 4 diopters of myopia and less than 0.75 diopters of cylinder. But it is available up to minus 7 diopters. And most importantly, it fits and handles identical to all of the other daily disposable soft contact lenses. If you currently fit and dispense single vision soft contact lenses in your office, you can fit and dispense the MiSight contact lens. Remember the monkey with the goggles that had the central holes for unobstructed central vision and the surrounding opaque area to defocus the peripheral retina? That design is incorporated into the MiSight lens, with the light purple region containing the patient's prescription and the dark purple regions containing plus 2.0 hyperopic defocusing elements. The peripheral elements have the potential to create some halos, especially if the patient is on low-dose atropine with some pupillary dilation, but have less than a handful of patients out of more than 150 current users who report any visual distortion. What are the advantages? The treatment is FDA approved, and the contact lenses are very easy to fit and adapt to, so it is a natural choice for myopic children who want to start using contact lenses. The biggest disadvantage is the lack of toric options for children with some astigmatism. Plus, they are about twice as expensive as standard daily disposable soft contacts. That's it for FDA-approved treatment options. All of the other options I will discuss are currently being used off-label. There are two multifocal contact lenses that are designed for adults with presbyopia that incorporate a center distance peripheral near design, Visionary Technologies' Natural View, and CooperVision Biofinity contact lenses. Even though these lenses were designed for presbyopia, they use optics similar to MiSight, with a central focusing region for distance vision and a peripheral ad for near vision that creates the peripheral defocus effect. Their main advantages over MiSight are lower cost and a greatly expanded range of focusing areas, up to minus 20 diopters of sphere and minus 6 diopters of cylinder, but there is limited data to support efficacy, and they are much harder to fit. I have an old timer who wears multifocal contact lenses for my presbyopia, and I was not able to achieve clear vision at both distance and near with either of these lenses. What about orthokeratology? Like the adult presbyopia multifocal contact lenses, orthokeratology lenses are FDA approved to correct myopia, but not FDA approved to control myopia progression. How does a temporary change to the central cornea curvature create a permanent reduction in myopia progression? The lens design provides the answer. The rigid contact lens flattens the central cornea to reduce foveal myopia, but does not change the peripheral cornea, leading to relative peripheral myopic defocus. In other words, orthokeratology creates the peripheral defocus, generating the desired multifocal optics by selectively compressing the central cornea while leaving the peripheral cornea intact. This Korean study, comparing central and peripheral focusing children with orthokeratology versus standard single vision contact lenses, demonstrates the refractive effect. After 2 weeks in the lenses, the single vision soft contact lens group, in blue, still averages about 3 diopters of central myopia without correction, unchanged from baseline. But the orthokeratology group, in red, only averages about 0.75 diopters of residual central myopia. The peripheral myopia, however, is virtually identical between the groups in the uncorrected state. When both groups are corrected to emmetropia, the single vision soft contact lens group now has peripheral hyperopic defocus, a signal for more myopic progression. But the orthokeratology group still has relative peripheral myopia. The retinal signal for myopic progression has been turned off. What about peripheral defocus glasses? There are no FDA-approved options for peripheral defocus spectacle lenses, but several lenses are available off-label in the United States. They all combine a central clear zone for distance vision with peripheral defocusing elements for myopic control. Every published study shows a benefit over single vision lenses, but there is some variation in the amount of reduction of myopic progression, with outcomes ranging from 30 to 70% less progression after 2 or more years on treatment. There's also some variation in the amount of peripheral image blur, although all studies say the lenses are exceptionally well tolerated, with greater than 95% acceptance. My personal favorite are lenses based on the Esler Stellus design. There is a clear central zone surrounded by concentric rings of focusing elements they call HALT, H-A-L-T, short for highly aspheric lensless targets, that work as microscopic peripheral defocusing elements. Why do I like these lenses the best? They report some of the best outcomes of all myopic control treatments, a 65% reduction in the rate of myopic progression, and more than 1 diopter less myopia than placebo after 3 years. Plus, I don't see any visible distortion with these lenses. Children can't tell they're wearing myopic control glasses. Another lens supported with strong randomized controlled trial data is the Hoya Myosmart. This lens has a central clear zone surrounded by a honeycomb of peripheral defocusing elements they call DIMS, D-I-M-S, short for defocus incorporating multiple segments. Studies report a 50% reduction in myopia progression over placebo that was sustained for 6 years, with no rebound after discontinuation. But I can detect a slight degradation in vision caused by the dense cluster of defocusing elements if I look a little bit off-center through the lenses. The last spectacle lens I'll talk about is the CooperVision Sight Glass lens. Instead of using a peripheral add to change peripheral hyperopic defocus into peripheral myopic defocus, this lens uses peripheral elements they call DOT, D-O-T, short for diffusion optics technology, to reduce contrast, similar to a Bangert foil. The contrast reduction is modest, barely detectable according to the authors, but I have not been able to judge for myself, since these lenses are not yet available even off-label in the US. The reported reduction of myopic progression is about 60%, intermediate between Myosmart and Stellus. Do optical therapies work? The animal studies and human trial data are very compelling. Peripheral hyperopic defocus stimulates myopic progression, either through a naturally prolate eye or induced by optical correction. Any reduction in this defocus by add power or reduced contrast slows myopic progression. Contact lenses have a theoretical advantage over spectacles, since they maintain the defocus elements in the proper position during eye movements. But spectacle lenses have the overwhelming advantage in that they can be used by all patients with no change in behavior. Down syndrome, autism, it doesn't matter. If the child can tolerate wearing glasses, they will receive the myopic control benefit. The lenses correct central vision, just like single vision lenses, but they include peripheral optics to slow myopia progression. Time for our third fact or fiction. No studies have demonstrated a long-term benefit for myopia control. The results from the CooperVision 6-year MySight trial, one of the longest and largest clinical trials ever conducted in children, suggest the results are durable and large enough to be clinically relevant. The first 3 years plot the change in SER for MySight in purple versus single vision contact lenses in orange. There is a large, almost 0.75 diopter treatment benefit. At 3 years, all control subjects were switched to MySight. From then on, the control group progression mirrored the original MySight study group. By 6 years, the original MySight group had progressed a total of about 0.92 diopters, equivalent to the control group at 2 years. Almost 1/4 of the children had no progression at all. This trial data is a major reason why MySight is an FDA-approved treatment option to prevent childhood myopia progression, and demonstrates that optical treatment can produce a durable and clinically meaningful reduction in the final level of myopia. What about low-dose atropine? The atropine treatment long-term assessment study, ATLAS, reevaluated subjects 20 years after ATOM 1 and 10 years after ATOM 2 to determine their final refractive outcomes and any incidence of myopia-related health complications. As might be expected, they were only able to acquire data from a minority of the original subjects, but nonetheless analyzed the available data and published their conclusions that there was no benefit in final refractive error or myopia-related complications for atropine. Was that conclusion actually supported by their data? The original ATOM 1 study compared atropine 1% versus placebo for 2 years, followed by a 1-year washout. The atropine was only given to one eye, leaving the fellow eye as a control, so there were actually 3 control eyes for every treatment eye. After 2 years, there was a very powerful treatment effect, with a more than 1 diopter benefit for atropine 1% over both placebo and fellow eye. There was terrible rebound in the washout year, however, leaving only a small residual benefit of less than 0.2 diopters for atropine 1% after 3 years. Fast forward 20 years later, and there was actually a slightly greater than 0.2 diopter benefit for the atropine 1% eye over placebo. Was the original treatment benefit lost over time? No, it persisted and increased slightly after more than 20 years. What about the fellow eye? Remember, it was 0.15 diopters worse than the atropine 1% eye after washout, but now it was 0.36 diopters better, for a net benefit of 0.5 diopters after 20 years that was borderline statistically significant. Why should we care about the fellow eye? Since some atropine is absorbed systemically, the fellow eye actually received low-dose atropine. The low-dose atropine eye had the best refractive outcome of all groups, an outcome that was borderline statistically significant despite the small number of remaining subjects at 20 years. For ATOM 2, there was no placebo group, so this was a comparison of atropine 0.01% versus 0.10% versus 0.50%. After 2 years of treatment, the 0.01% group was about 0.3 diopters worse than the other groups. But after 1-year washout, plus restarting 0.01% as needed for progression over the next 2 years, the atropine 0.01% group ended up about 0.3 diopters better than 0.1% and almost 0.7 diopters better than 0.5% after 5 total years. Fast forward 10 years, and atropine 0.01% had a 0.4 diopter benefit over 0.1% and almost 0.8 diopter benefit over 0.5%. Intermittent treatment with atropine 0.0% over 5 years created a durable treatment benefit 10 years later. More importantly, the 0.01% group had half the incidence of myopic macular degeneration compared with the atropine 0.5% group. That 0.8 diopter reduction in final refractive error really made a meaningful difference in clinical outcomes. This is the first time that low-dose atropine demonstrated a medical benefit, not just a reduction in myoprogression, in a long-term clinical trial. The ATLAS study contains some important lessons. The first and most important lesson is to not conflate no statistically significant difference with no difference. Statistical significance depends on the magnitude of the effect and the number of subjects. You need a much larger treatment effect to demonstrate significance in a small number of subjects. For ATLAS, the long-term treatment effects were actually slightly better at 10 and 20 years than at the end of the original studies, but statistical significance suffered from the loss of the majority of subjects. Instead of demonstrating that a short course of atropine did not create a lasting change in final refractive outcome, the published results demonstrate there was a lasting change in refractive outcome that did not achieve statistical significance because so few subjects completed a long-term follow-up. The two major findings of the ATLAS study were that a relatively short course of treatment created a sustained reduction in final refractive error, and reducing total progression by less than 1 diopter cut the prevalence of myopic macular degeneration by 50%. Going back to my daughter and her orthodontic treatment, using the palate expander and braces for a year before age 10 would have created a durable and meaningful improvement in her teeth alignment. But she required ongoing care and retreatment, ended with perfect teeth as an adult. We should approach childhood myopia with the same mindset. Long-term observational studies demonstrate that more than half of children continue to have myopia progression after age 15, and almost a quarter after age 17. Do we really believe that 2 or 3 years of treatment between the ages of 6 and 12 will create the maximum health benefit that can be achieved with myopia control? It is clear that the best final refractive outcome will require years of treatment. Time for our fourth factor of fiction. Controlling myopia progression in children is worth our time and effort. Years of treatment seem daunting and expensive, both in clinic time and actual dollars. Is it possible to place a monetary value on good eye health? After all, next to life itself, good vision is a foundational part of a healthy, joyful existence. How much should we pay for a significant reduction in a child's lifelong risk for developing cataracts, glaucoma, or retinal diseases? In medicine, we have created a measure quality-adjusted life years to provide some estimate of the cost to achieve 1 additional year of perfect health. $50,000 is considered a reasonable value for adding a single year of perfect health. Using artificial intelligence, it is possible to estimate that controlling child myopia progression would cost between $1,000 to $5,000 per quality adjusted life year, depending on the treatment modality, making it highly cost effective. For comparison, detecting and treating amblyopia would cost about $3,000 per quality adjusted life year, glaucoma $14,000 to $17,000, and macular degeneration $21,000 to $50,000. If you believe that treating these conditions are important and worthwhile, then you should believe that myopia control in children is important and worthwhile. To place the oncoming tsunami of future myopia-related complications into perspective, each year the government sets up a budget that allocates money from Medicare and Medicaid. Budget neutrality means that any estimated increase in spending in one area must be offset by a reduction in spending in other areas, so that there is no net increase in expenditures. So if a new expensive Alzheimer's treatment is approved, there is less money for cataract surgery. What happens to the allocation of resources if the rate of retinal detachment doubles or triples? Normal attention glaucoma, myopic macular degeneration. There is a fixed pot of money, so more money will go into those treatments, and the reimbursement for each treatment will decline. Plus, less money is available for all other medical care, not just eye care. Prevention is the much better choice. What about your personal time and effort? You are a highly skilled eye doctor. Do you want to spend valuable time in your clinic counseling patients and parents about the benefit of myopia control? The short answer is that you will not need to devote very much time and effort at all. I'll go back to my example of the orthodontist and braces. Every parent wants their child to have straight teeth, so there is no counseling. Just identify the problem and recommend treatment. No parent wants their child's vision to get worse, so identify the problem and recommend treatment. Choose the best option for that patient and delegate counseling to your staff. Your role is still crucially important. The patient and parent are there because of your professional expertise, and they will trust your advice on treatment. Explain the risk. Your child's eyes will get worse without treatment, and legitimize treatment. There are effective options available to decrease the risk. That's it. Less than 2 minutes of your time to advocate for a lifetime of good vision. Here is where official policy statements from our professional organizations can make a big difference in reducing the time and energy you need to expend. No one goes to the car dealership and asks for the cheap car, the one without airbags and seatbelts, because they're on a budget and can't afford the additional safety features. The government forbids you from taking that chance with your life. Until the government takes the same action to forbid single-vision glass contact lenses in myopic children, the American Academy of Ophthalmology and the American Optometric Association should advocate that myopic children be given peripheral defocus glasses and contact lenses that mitigate, not increase, the harm from myopia. Our professional organizations should work with overseas lens manufacturers to make these spectacle lenses widely available off-label, as is currently permitted, instead of waiting for formal FDA approval. Then, your myopia care will be virtually identical to your current practice. You advise the parents to make sure the glasses have peripheral defocus technology to slow the worsening of the child's vision when you hand them their refraction. Even without official policy statements, the internet and artificial intelligence can help. I prompted ChatGPT with, "My child has been diagnosed with myopia. Should I start treatment to slow progression?" It responded with, "Yes, it's definitely worth considering starting treatment to slow the progression of a child's myopia. Myopia, nearsightedness, often worsens during childhood and adolescence, and early intervention can help reduce the risk of developing high myopia, which is associated with a greater likelihood of eye disease later in life, such as retinal detachment, glaucoma, and myopic maculopathy." It then listed treatment options: low-dose atropine, orthokeratology, multifocal glasses and contact lenses, and even lifestyle changes. It took less than 5 seconds to generate this content. You don't have to spend much time. Just identify the problem and recommend treatment. Time for our fifth fact or fiction. Controlling child myopia should be the standard of care. The standard of care is a medical legal term that refers to the level of care that a competent medical professional in your local community would use when presented with a given clinical situation. What would be the standard of care in your community if a patient presented with this set of fundus photos? No other clinical history. Given that this talk is about myopia and the early peripapular crescents around each optic nerve, you might correctly guess that this patient is myopic with clinical signs of globe elongation. There is also asymmetric cupping with a slightly enlarged cup-to-wrist ratio in the left eye. Given the increased risk of glaucoma with myopia, you would definitely want to check the intraocular pressure and perhaps measure the central cornea thickness and obtain a baseline optic nerve OCT. These photos were from an 11-year-old Chinese girl who came to my office last December. Her vision was 20/320 and 20/400, and her -1.5 glasses from the prior year. Her new refraction was minus 3.75 and minus 4.0, and her axial length was over 25 millimeters, compared with the normal adult average of 24.5 millimeters. Her last eye doctor did not mention myopia control at all. Did that doctor violate the standard of care? I don't think so, since myopia control still has not been adopted as a standard of care by professional organizations. Did he provide this patient with good care, given her age, ethnicity, high likelihood of progression, and the existence of an FDA-approved treatment option, the MiSight contact lens, for her condition? Definitely not. In 2025, you should expect better, especially if this patient was your own child. The core principles of the Hippocratic Oath are non-maleficence, do no harm, and beneficence, act in the patient's best interests. Our major organizations, AAO, AOA, APOS, and even the FDA, are failing those core ethical principles. The fundamental disconnect, the fundamental lack of understanding, is that we are harming today's myopic children if we follow today's standard of care and give them single vision glasses and contact lenses. We are prescribing our children medical devices that signal the eye to elongate and the myopia to worsen by creating peripheral, retinal, hyperoptic defocus. Because of that simple fact, we cannot afford to wait to doom another generation of children to higher and higher levels of myopia while we search for the perfect treatment. Instead, we have safe and reasonably effective treatments that we can use today while we continue to look for better and more effective treatments in the future. An important point to remember is that there are no significant risks to myopia control treatments. Atropine 1% has been FDA approved since 1960 and can be used up to twice per day in children 3 years or older. Low-dose atropine has equivalent safety to placebo in all the clinical trials. No harm has occurred for any of the optical treatments, except for a slightly higher incidence of corneal problems with orthokeratology. The main downside risk for all current treatments is the potential lack of benefit for continued progression of myopia, not an adverse health outcome. Another key point to remember is that FDA approval is not required to create a standard of care. Many medications are used off-label as part of the standard of care, such as intravitreal avastin injections for retinopathy prematurity. FDA approval is also not required for optical devices, such as frames and lenses. There are manufacturing standards to control shadow resistance and other properties, but pre-market approval is not necessary. If FDA approval is not required, why don't the major lens manufacturers make their peripheral defocus lenses available off-label? I believe they're more concerned about marketing and pricing and maximizing good outcomes for our current patients. The FDA does not allow any product that is going through the approval process to be released prior to approval, and the lens manufacturers believe that formal approval will allow them to market and price lenses as premium products. Because lenses are approved in many markets outside the United States, however, smaller lens manufacturers that are not able to complete the large clinical trials required by the FDA are willing to ship lenses to optical shops for use right now. Peripheral defocus spectacle lenses can be dispensed to our patients in the United States today without requiring a trip to Canada or Asia. I believe a myopia control standard of care should include 3 simple but foundational elements. First, myopia should be classified as a disease that requires monitoring to minimize adverse outcomes, just like glaucoma. That way, health insurance should cover myopia control visits and ancillary testing, like axial length measurements, that are necessary to monitor disease progression. Second, myopia suppression treatment should be started at the time of diagnosis without waiting for progression. Because axial elongation is irreversible, starting treatment early without giving up unnecessary ground is vitally important to achieving the best refractive outcome. And third, eye doctors should exercise their best clinical judgment regarding on-label and off-label treatment options. Our myopia control options will evolve over time as better treatments become available. Plus, each patient will have a unique response to treatment. As long as the eye doctor initiates treatment, monitors for progression, and adjusts the treatment based on the clinical response, he or she is following the standard of care. What is my current clinical practice based on the available evidence? For early myopia, less than 0.75 diopters, I avoid glasses if at all possible. It is hard to justify the cost of peripheral defocus glasses with such a light prescription, but I don't want to prescribe single vision glasses that will make the myopia progress more quickly. Instead, I just prescribe low-dose atropine, which works wonderfully well in this population, and try to delay the need for glasses as long as possible. For moderate myopia in older children, I will start with just peripheral defocus glasses or contact lenses. These children need correction, so making the optical correction for myopia control treatment simplifies compliance and is quite effective for this age group. For the younger patients at higher risk for rapid progression, I typically have a combination therapy using both peripheral defocus and low-dose atropine. These children have so many years of progression ahead of them that I want to cut the rate of progression as close to zero as possible. Finally, for the highest risk patients, such as the Chinese girl with axial elongation, I will start peripherally focused and higher concentrations of atropine. I follow these patients every 6 months. I don't routinely perform cyclovision refractions. Stable corrected vision and dry retinoscopy with a child fixing a distant target is usually enough to confirm minimal versus faster progression. I also don't measure axial length at every visit, reserving that measurement for the higher risk patients. I consider any increase in myopia more than 0.25 diopters as clinically significant and will escalate therapy, typically adding low-dose atropine to peripheral focus or increasing atropine concentration up to 0.05%. If they are stable for several years, I will try to wean them off atropine, but I'll maintain peripheral focus until they're much older. Going back to the goals of this talk, I believe the existing evidence, which is very likely the cleanest and best data that we'll ever be able to obtain, supports the safety and efficacy of myopia control treatments in children. Beneficence demands to act in the patient's best interest by making myopia control the standard of care to maximize the chance of a lifetime of good vision. Non-maleficence demands that we stop giving myopia children single vision glasses and contact lenses, optical devices which will actively make the myopia worse. Instead, you should be given peripherally focused glasses or contact lenses to remove the peripheral hyperoptical signal that drives faster myopia progression. Finally, there is a significant role for low-dose atropine to delay or even prevent the need for correction and to augment optical therapy, especially in younger, higher-risk patients. Now, let's revisit some of the fact or fiction statements. We should control myopia progression in children. Clearly, the statement is fact. That is not just my opinion, but the official policy of our professional organizations. Myopia control in children is possible. There are legitimate debates about how effective various treatments might be and whether the long-term outcomes justify the time and expense. But there should be no debate that treatment can slow down myopia progression. To argue otherwise is to ignore a literal mountain of supporting randomized controlled trials. No studies have demonstrated long-term benefit from myopia control. This statement is probably the most contentious, but I'll turn the question around and say that current optical treatments, single vision glasses and contact lenses, have proven to be harmful for our children's eyes. Their widespread usage has contributed to the absolute epidemic of higher and higher levels of childhood myopia. With no known downside risk for optical treatment, simply replacing single vision correction with peripheral defocus will provide, at a minimum, a long-term benefit on a population level. The next statement, controlling myopia progression is worth our time and effort, is the most subjective. I believe it is worthwhile, but worth is a value assessment that depends on each doctor's internal judgment of the costs and benefits. At a minimum, every eye doctor should at least acknowledge the downside of unrestricted myopia progression and direct patients and parents to community resources if he or she does not want to offer myopia control services. Time for the last and most important factor of fiction. Controlling childhood myopia should be the standard of care. You know where I stand on this statement, but if you don't believe this to be true, you will have to justify to yourself and your patients why you think the orthodontist is more important than the eye doctor, why straight teeth are more important than a lifelong reduction in the risk of uncorrectable vision loss. If you believe in the Hippocratic Oath, you'll have to justify why you continue to prescribe single vision correction. Finally, the ultimate truth serum is how you would treat your own children or grandchildren if they develop myopia. Would you be content to let their myopia worsen over time, or would you take steps to mitigate future harm and maximize their chance for a lifetime of clear vision? While preparing for this talk, I surveyed 28 eye doctors, mostly pediatric ophthalmologists, but also some pediatric optometrists, who currently use myopia control for their patients. The response rate was 75%, and some of the answers were quite informative. The first question was, do you believe that currently available treatment options can significantly slow the progression of myopia in most children? Over 90% said yes. Next question, do you use atropine eye drops in any concentration for myopia control? 100% said yes. Every eye doctor who prescribes myopia control uses low-dose atropine. Why? Compound low-dose atropine is widely available. If a myopia control treatment is widely available, eye doctors will use it. Next question, do you use peripheral defocus contact lenses? I was surprised that only 81% said yes, since there is an FDA-approved peripheral defocus contact lens, MiSight. So 100% currently use low-dose atropine off-label, compared with 80% who use MiSight on-label, demonstrating once again that FDA approval is not required to establish a standard of care. Next question, do you use peripheral defocus spectacle lenses? Even without an FDA-approved option, almost 40% have access to and use peripheral defocus spectacle lenses. Next question. Pending FDA approval, would availability of off-label peripheral spectacle lenses expand your usage of them? For the eye doctors without current access to off-label peripheral lenses, over 60% would moderately or significantly expand their usage of them if we could improve access. Eye doctors want access to the optical devices that can be used by all patients that have proven to be effective across years of treatment in multiple randomized controlled clinical trials. Thank you for taking the time to listen to my lecture. Please reach out with your questions and comments.